Thank you very much. We will still go on, and after having had so much numbers in mind to choose really what to do, I will try to make things simple or without too many numbers, just for specific type of patients. This is my disclosure, and I must also thank Pascal for the video we will see at the end. So what are we talking about? Right now, we know that reverse shoulder arthroplasty can restore easily the forward flexion, the active forward flexion, but not the active external rotation if both the infraspinatus and the teres minor are absent or functionally absent. So this morning, Philippe Valenti clearly explained us what the clear patient is. And what I will talk about is for those specific patients that has a combined loss of elevation and external rotation. For us, those patients are candidates for a reversed associated with tendon transfer that has already been published in the past. So the initial concept was to do, through a deltopectoral approach, detachment of the pectoralis major, then the teres minor and the Latissimus Dorsi were harvested, and then turn around the humeral proximal humerus, and then sutures to the tendons laterally. Then the pec major, of course, was repaired. It was the modified Lepiscopo procedure associated with the reverse. What were the results of for those patients? This is a nice study, a systematic review of the literature that combined 116 patients. Of course, we are speaking of a restricted population of patients. This is a restricted indication. So 116 patients. And the mean gain was just good in terms of constant score that increased from 25 to 62. It was excellent for the external rotation. Those patients that were unable to have an active external rotation can have up to 30 degrees of external rotation, and of course the active elevation was restored. But you see the difference, and the standard deviations for those patients were quite great, so it was not so predictable. You see everything, so the constant score increase of 40 points and the external rotation of 30 degrees in mean. But this surgery was associated with a high rate of complication, up to 26. And in the different complications that were observed, 6% of them were related to the tendon transfer especially. There were 5 nerve palsy that can be considered as a severe complication, 1 subluxation, but the explanation was just because the pectoralis major was probably been harvested and not healed well. And secondary partial tear of the transplant, and mainly the teres major, there was a rupture of the teres major. There was also 10% of complication related to the reverse shoulder arthroplasty, the 6 infections, 4 dislocations. Explanation also with the pec major detachment, we don't know. 1 periprosthetic fracture and 1 aseptic loosening. That's, I mean, the usual complication and usual complication rate we observe with this kind of surgery. So 26% of complication rate, and 1 more new complication. This kind of bone loss on the lateral side of the humerus. And the explanations were probably because the tendon transfer was put around the proximal humerus, sutured to the remnant tendon, and then there was some shearing forces next to the bone, next to the lateral cortex of the humerus, and that's why this appears. And we don't really know what's going on with this and how to do with this. Must we be afraid or not? So the new concept, the evolution of the concept, was to still doing the surgery in a deltopectoral approach, do a latissimus transfer isolated with a bioassay and the evolution of the prosthesis, and then put it in a keyhole to make sure that it will probably heal and will not put these sharing forces around the humerus. So that's the technique. It's done with a deltopectoral approach, single deltoid approach, as just always. All the scarring tissues were harvested. This is the humeral head. You can see that there's nothing in the back. The pec major is identified, then elevated to find in the back the Latissimus dorsi and the teres major. The Latissimus dorsi must be cleared of all the attachments, local attachment, debrided and clearly isolated. This is the tendon. All the fascia expansions must be cleared off, especially from the bottom of the scapula. Then the tendon is prepared in Krakow stitch fashion that made sure that it will fit in the keyhole. Then it's passed through and through the teres major and put around the humeral head and neck. Then, when it's brought in the front, the keyhole is done, prepared as always. And then the surgery continue. It put in the back. The biceps tendon is tenotomized and fixed. The 3 sisters are controlled. Then, in the front, the biceps is excised, cut, the subscap is prepared for the end of the surgery. Then a normal, regular bioassay is prepared in normal fashion to make sure that we will lateralize from the glenoid side and with the new implant a little bit on the humeral side. This is an asymmetric to correct the deformity of the glenoid more than to lateralize it. It's fixed with the 4 screws. Then a normal glenosphere is put on. Then the humerus is prepared as always. This is for the subscap repair, for transosseous repair. And then finally, the Latissimus dorsi tendon is transferred and fixed with this little plate onto the bicipital groove where the strongest bone is. Then the prosthesis is put on, the subscap is repaired, and the surgery is done. So the demographic for the new series, it's one more time a small series of 37 patients done for cuff tear arthroplasty. This is the results in terms of forward elevation, 73 degrees in mean. That is the external rotation, like the previous series, something like 30 degrees of external rotation regain. This is the internal rotation. This is the constant score, also a significant progress in the constant score. So, to conclude, with the radiographic analysis, with this new technique, with the keyhole transfer, there's no more lateral cortex problem observed. So it's this surgery is already available for the clear patients. It will restore elevation and external rotation without loss of internal rotation because the pec major is not detached or not torn. It can be done in a single deltopectoral approach. Thank you very much.